Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 286 of our pharmacotherapy series, which majors in thrombosis. The first question reads, KGB is a 72-year-old woman with a deep vein thrombosis that occurred during her hospital stay. On day 4 of heparin therapy, she received a full bag of 25,000 units of heparin during a 1-hour period as a result of an infusion pump malfunction. The infusion was stopped and within 30 minutes, she became diaphoretic and hypotensive. Bright red blood was evident on rectal examination, and a large retroperitoneal mass was noted. So my question to you is, how should the excessive heparin effect be reversed? KGB has definite signs of hemorrhage from the GI tract, a site of bleeding associated with considerable mortality. Heparin should be discontinued immediately, and treatment should include maintenance of fluid volume and replacement of clotting factors with whole blood, fresh frozen plasma, or clotting factor concentrates. If hemorrhage had not been present and the only manifestation of overdose had been a prolonged activated partial thromboplastin time, administration of heparin simply could have been discontinued, permitting the effects to clear within a few hours. Protamine can be used to neutralize heparin by forming an inactive protamine-heparin complex. Protamine has a rapid onset of action, with effects lasting about 2 hours. Protamine sulfate is infused solely over 3 to 5 minutes, as a 1% solution at a dose of 1 mg for each 100 international units of heparin administered in the last 2 to 3 hours. The maximum single recommended dose of protamine is 50 mg, but doses may be repeated if bleeding persists. Response to protamine therapy can be assessed by a return of the activated partial thromboplastin time to baseline. Adverse effects associated with protamine include systemic hypotension secondary to rapid administration, anaphylaxis characterized by edema, bronchospasm, and cardiovascular collapse, and catastrophic pulmonary vasoconstriction. The next question reads, KNC is a 32-year-old woman who presents to the emergency department complaining of right leg pain behind the right knee of 2-day duration. She denies recent injury, but her medication history reveals that she recently started combination oral contraceptive tablets. She has no significant medical history and has no family history of clotting disorders. A duplex ultrasound is positive for deep vein thrombosis and immediate anticoagulation is indicated. What therapeutic alternatives to hospitalization for IV unfractionated heparin are available for this patient? In the past, unfractionated heparin was the initial treatment of choice for acute deep vein thrombosis. However, low molecular weight heparins and fondaparinux are now becoming more convenient and practical treatment alternatives to unfractionated heparin. These agents, administered subcutaneous and without the need for routine coagulation monitoring, allow patients to be treated at home while transitioning to therapeutic warfarin. In addition, meta-analysis data suggest that low molecular weight heparin therapy for acute venous thromboembolism results in fewer deaths, major hemorrhages, and recurrent venous thromboembolism when compared to unfractionated heparin. Based on these advantages, outpatient use of low molecular weight heparin has become the most common approach to treatment of uncomplicated deep vein thrombosis in patients that transition to warfarin. Home treatment is safe and effective and improves the overall physical and social functioning of patients being treated for deep vein thrombosis. The drug costs associated with low molecular weight heparin treatment are much higher than the costs of IV unfractionated heparin, but overall costs to healthcare systems are significantly reduced when patients can be treated at home rather than in the hospital. Fondaparinux can also be considered as an alternative treatment as it has been shown to be as effective and safe as low molecular weight heparin in the treatment of deep vein thrombosis. Additionally, weight-based subcutaneous unfractionated heparin, initial dose of 333 international units per kilogram followed by 250 international units per kilogram every 12 hours without routine activated partial thromboplastin time monitoring while patients become therapeutic on warfarin is an alternative for the treatment of acute venous thromboembolism. Vials of unfractionated heparin at a concentration of 20,000 international units per milliliter are used by the pharmacy or the patient to draw up the weight-based dose. Although routine activated partial thromboplastin time monitoring is not necessary, platelet count monitoring during the first 2 weeks is required to evaluate the possible development of heparin-induced thrombocytopenia. For KNC to be treated at home with low molecular weight heparin, she or a family member must be willing and able to administer subcutaneous injections, and she must be able to return for frequent follow-up visits, particularly during the first few weeks while warfarin therapy is initiated. In addition, her healthcare insurance should cover the cost of the drug, or she must be able to pay out of pocket. Contraindications to outpatient treatment of venous thromboembolism include a pre-existing condition that requires hospitalization, clinical symptoms of pulmonary embolism with hemodynamic instability, and recent or active bleeding. KNC meets the eligibility requirements for home treatment of her deep vein thrombosis. She is also a suitable candidate for a direct oral anticoagulant and prefers to not have to perform self-injections of medication. Currently, there are 2 direct oral anticoagulants, rivaroxaban and apixaban, approved in the United States for monotherapy and do not require an initial period of parenteral anticoagulant. Advantages to the use of a direct oral anticoagulant compared to warfarin include the lack of routine monitoring for assessing drug efficacy, fewer drug and food interactions, and a lower rate of major bleeding compared to warfarin. Currently, only dabigatran has an FDA-approved agent for reversal, idarucizumab, and there are several other reversal agents in clinical trials. The lack of reversal agent leaves some providers and patients apprehensive to their use. When selecting a direct oral anticoagulant, it is important to know the patient's renal function because these agents have varying doses based on current renal function. A baseline CBC should also be checked, because all anticoagulants have the potential for bleeding, and it is important to know the baseline hemoglobin level in case bleeding occurs on treatment. In this case, KNC received an injection of low molecular weight heparin while in the emergency department, and rivaroxaban is selected for monotherapy, at 15 mg twice daily with food for 21 days, followed by 20 mg daily with food for the remainder of her 3-month duration of treatment. KNC should be advised to follow up with her primary care provider regarding her new diagnosis, and it should be stressed to the patient the importance of proper transitioning of the dose from the twice-a-day to the once-a-day schedule. Anticoagulation clinics may also be involved in KNC's care to follow up and make sure she was able to obtain the medication without insurance barriers, that the direct oral anticoagulant dose was appropriate, that her deep vein thrombosis symptoms are improving, that she is tolerating the medication, and that she transitions to the correct dose appropriately. Higher-risk patients, such as those with lower health literacy and multiple medical problems, may benefit from face-to-face clinical visits if this information cannot be obtained by telephone. Centralized anticoagulation services are expanding beyond traditional monitoring to include patients on direct oral anticoagulants by prospectively following them to ensure optimal therapeutic outcomes. There are some cases where it may be necessary to test whether the direct oral anticoagulant is present, such as in a patient with acute stroke, need for urgent surgery, or in the case of major bleeding. There is no current consensus on how best to do this, because the tests that correlate the best are not often readily available. Of those that are readily available, activated partial thromboplastin time or thrombin time are often used to detect dabigatran presence, and the prothrombin time or anti-factor Xa calibrated for the factor Xa inhibitors. The next question reads, during a follow-up call to KNC from the anticoagulation clinic the next morning, it is discovered that KNC was not able to get the rivaroxaban filled at her pharmacy last night because her insurance does not cover any direct oral anticoagulant therapy without first documenting a treatment failure to warfarin. What alternative treatment is available for KNC? Before the direct oral anticoagulants, treatment with self-injected low molecular weight heparin bridging to warfarin at home was the standard of care. In this case, enoxaparin is the low molecular weight heparin preferred by her insurance because it is available generically. The usual dosing of enoxaparin for treatment of deep vein thrombosis is 1 mg per kilogram total body weight subcutaneously every 12 hours, rounded to the nearest 10 mg increment. Once daily dosing at 1.5 mg per kilogram subcutaneously every 24 hours is also an option, but this strategy is inferior to twice daily dosing in patients with malignancy or obesity. KNC's medical history is suitable for the once-daily dose of enoxaparin, which is more convenient for administration. At 65 kg, a dose of 1.5 mg per kilogram would be 97.5 mg, which will be rounded to the nearest 10 mg increment. KNC will therefore receive 100 mg subcutaneously every 24 hours. Warfarin therapy is initiated concurrently to expedite the conversion to oral treatment. Because low molecular weight heparins are eliminated renally, patients with significant renal impairment require dose reductions to prevent drug accumulation and to minimize the risk of bleeding complications. The degree of drug accumulation can vary between the various low molecular weight heparin preparations, and thus specific guidelines for dose adjustments are agent-specific. Some experts suggest monitoring of anti-factor Xa activity to rule out accumulation of low molecular weight heparins in patients with renal impairment who are on treatment for extended periods of time, i.e., greater than 1 week. Fondaparinux is also renally excreted and is contraindicated in patients with creatinine clearance less than 30 ml per minute. KNC should be educated regarding the potential adverse effects of low molecular weight heparin therapy such as bleeding, thrombocytopenia, pain and bruising at the injection site, required laboratory monitoring, and the expected duration of anticoagulation. At baseline, hemoglobin and/or hematocrit (INR), serum creatinine, and platelet count should be determined. Platelets will continue to be monitored at least every 2 to 3 days while the patient is receiving low molecular weight heparin therapy, to a maximum of 10 to 14 days. KNC can expect to continue enoxaparin therapy for a minimum of 5 days. If by day 5 her INR is therapeutic and stable, enoxaparin can be discontinued. Oral anticoagulation with warfarin should be continued for 3 months. KNC should also be advised against further use of estrogen-containing contraceptives. To ensure the safety and efficacy of home treatment, KNC should be provided with the names and telephone numbers of the healthcare providers who will assume responsibility for her care, including her primary physician and her anticoagulation management team. No patient should be sent home with low molecular weight heparin without an adequate follow-up plan. The next question reads, MOG, a 63-year-old obese man, is to undergo elective abdominal surgery for treatment of an umbilical hernia. He has a medical history significant for hypertension, currently controlled by enalapril 10 mg daily with a blood pressure is 130 systolic 80 diastolic, and gout, controlled with allopurinol 300 mg daily. What therapeutic interventions might decrease the risk of deep vein thrombosis or pulmonary embolism in MOG? Surgical procedures represent a significant risk factor for deep vein thrombosis formation. However, all hospitalized patients, including both surgical and non-surgical or medical patients, should be stratified for risk of venous thromboembolism based on the presence of various factors. Risk stratification is used to select the most appropriate therapeutic interventions to prevent deep vein thrombosis and thereby reduce the risk of fatal pulmonary embolism. These interventions include both mechanical and pharmacologic strategies. Regarding the non-pharmacological measures, mechanical interventions aimed at preventing venous stasis and increasing venous return include the use of elastic compression stockings, as well as leg elevation, leg exercises, and early postoperative ambulation. Intermittent pneumatic compression, abbreviated as IPC, of the leg muscles, using inflatable cuffs applied to the calf and thigh, represents another alternative for the prevention of deep vein thrombosis. Because it is generally less effective than pharmacologic prophylaxis, mechanical prophylaxis is most commonly used in patients at high risk of bleeding, or as an adjunct to pharmacologic prophylaxis in patients at very high risk for venous thromboembolism. Regarding the pharmacologic measures, fixed, low-dose unfractionated heparin, abbreviated as LDUFH, administered as 5,000 units subcutaneously every 8 to 12 hours depending on the indication, is an inexpensive and effective pharmacologic approach to deep vein thrombosis prevention in the setting of venous stasis in patients with acute medical illness, or after certain surgical procedures. Because low-dose unfractionated heparin inactivates factor Xa without a direct effect on factor IIa, the activated partial thromboplastin time is not prolonged, and therefore activated partial thromboplastin time monitoring is unnecessary. Bleeding complications are minimized using this dosing regimen. Fixed-dose subcutaneous low molecular weight heparin and fondaparinux are alternative approaches for preventing deep vein thrombosis. Enoxaparin 30 mg subcutaneously every 12 hours or 40 mg subcutaneously once daily, dalteparin 2,500 to 5,000 international units subcutaneously once daily, and fondaparinux 2.5 mg subcutaneously once daily are effective strategies, although enoxaparin has been studied for a larger number of indications. The direct oral anticoagulants rivaroxaban, apixaban, and dabigatran have been FDA approved for deep vein thrombosis prophylaxis in orthopedic surgery patients. Betrixaban 160 mg as a single dose followed by 80 mg daily is approved for venous thromboembolism prophylaxis in adult patients hospitalized for an acute medical illness. MOG is at high risk for deep vein thrombosis and pulmonary embolism, not only because of general surgery but also because of his age, older than 40 years, and the presence of other risk factors for venous thromboembolism, such as obesity, and probable postoperative immobilization. Options for deep vein thrombosis prevention include subcutaneous heparin at 5,000 international units every 8 hours or a low molecular weight heparin, enoxaparin 40 mg subcutaneously daily, or dalteparin 2,500 international units initial dose followed by 5,000 international units subcutaneously daily. The first dose should be administered several hours preoperatively, and dosing should continue postoperatively until he is fully ambulatory. If bleeding risk is of concern, intermittent pneumatic compression could be used as an alternative. Venous thromboembolism prophylaxis is typically continued until hospital discharge, but may be continued for up to 30 days in certain high-risk populations, including patients with cancer, orthopedic surgery, bariatric surgery, or with a prior history of venous thromboembolism. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 287.